شكرا كتير عشان عزموني لهذا الكونفرنس. أول شيء سؤال عندي شوية معلومة عشان هيك أعطوني وقت زيادة ولا بدي أحكي بروسي؟ واحد من الاثنين, شو ما بدكم. طب أوكي, сегодня мы начинаем говорить по полицейский cover синдром. لا بس أنا كنت شايفة في واحد اثنين مش فاهمين روسيا, عشان هيك بدنا نحترمهم, بدنا نحكي من إنجليزي. Okay, today we are talking about PCOS or PCOS with the high comorbidity in this syndrome, and still there is unsatisfaction and high rate of depressive disorder and anxiety in women. And I want also to underline some moment, a moment we have or have not used in our daily practice. Polycystic ovary syndrome, it take names, his name from its name as a multiple arrested, not untreated. It's very important in pathophysiology of this syndrome, arrested follicles in women with hyperandrogenism, oligo or amenorrhea, and with sometimes associated with high degree of comorbidities like insulin diabetes, dyslipidemia, and endometrial cancer, and also some psychiatric disorders. It's most common cause of anovulatory infertility, and the prevalence rate it's about 15%. Current management of polycystic ovary syndrome is ad hoc and symptomatic. There is a symptom has a heterogeneous presentation with insult in intrauterine environment, in intrauterine life, and continue through the lifespan, dependent on some phenotypes and ethnicity of the patient. There is variability in presentation according to phenotype, with the more hirsute woman in the Mediterranean region. Okay, in Mediterranean region, Hispanic and also Middle East woman. And when patient come in my outpatient clinic, and she's afraid about name of Takayus Mabayat, the first statement I tell her that because we are living in Mediterranean region, it's very often to see women with hirsute woman. It's normal, and don't write about your future fertility. And with large amount of metabolic, high rate of metabolic features in southeast, like you can see in blue one. Okay. Pathophysiology of PCOS is help us to understand diagnostic criteria and also treatment for this syndrome. And normally, just to remember, and all over the cycle, the main role of estrogen and progesterone is suppression for GnRH and LH expression, except in middle cycle, which estrogen has positive feedback for hypothalamus to induce ovulation. Polycystic ovary syndrome is characterized by increased androgen, insulin secretion, and increased pulsativity, mainly more than frequency, more than amplitude of GnRH hormone. Okay, now because of increase of GnRH pulsativity, it's lead to increased LH surge and action of the cells of the ovary with increased production of androgen hormones. And diminished or unaltered action of FSH lead to small expansion of follicular size and development, which lead to increase production of also anti-Müllerian hormone. Anti-Müllerian hormone also have two actions, direct to GnRH, and also in the TECAT cells, it inhibit CYP system, CYP system, with conversion of androgen to estrogens. Another important sign or picture in polycystic ovary syndrome is insulin resistance. First described in 1980. هذا الآن مش معروف what relationship between insulin resistance and polycystic ovary syndrome. But in pathophysiology, there is the increase of insulin because of insulin resistance in peripheral organ. Insulin in polycystic ovary syndrome, this have bidirectional action. In adrenal and ovarian tissue is increased CYP sabotage, expression of CYP sabotage enzyme with production of high level of steroid hormones or androgen. And in peripheral tissue, it decrease action of insulin, most probably because of replace tyrosine phosphorylation by 4-serine phosphorylation, and it lead to a decreased uptake of glucose in peripheral tissue, with consequence increase of liponeogenesis in the liver, glycogenesis. This lead to increase in hyperinsulinemia per se. It also increase production of GnRH hormones. Also insulin also in the ovary increase production of androgen by increased production of CYP sabotage with increased 5-alpha reductase. As we know, it's lead to conversion of progesterone to androstenedione. Because of it, we see androstenedione high in laboratory investigation. Okay. Heritability of PCOS, it run in cluster in family with high heritability to approaching to 70%. Interaction between genetic and epigenetic factors, which lead to variable inheritance with different phenotypes in the daughter of women with PCOS. Daughter of women with PCOS have 5 times more likely to be diagnosed with PCOS. Okay, there is some susceptibility loss found in the woman with diagnosed with PCOS, and one study was first done by one Chinese researchers in one area in Han Chinese woman, and they defined about 19 lots of forces responsible for PCOS in this Chinese woman. But some of them, like DEN and LHCGR, the two receptors responsible for increased androgen hormone secretion in TECAT cells, and also thyroid adenoma-associated protein, which is responsible for high level of insulin or for insulin resistance. Also, this gene was found positive in European woman, which lead to thinking that it's not related to ethnicity. Epigenetic factors, some environmental factor like high level of anti-Müllerian hormone or androgen, when fetus exposed to woman with high level of this hormone, they diminish function in placental function with decreased aromatase activity. We know that our fetus it protected from high androgen level in the mother. But here, because of high level of this hormone and AMH, placental function is diminished with the spillage of this factors to the baby, affecting development of stem cells, not just stem cells, also somatic cells, with some epigenetic and genetic changes in gestone modification or in DNA methylation. Daughter of PCOS of PCOS woman had elongated anogenital distance. It like a woman with congenital adrenal hyperplasia. They also have elongated this distance. Polycystic ovary syndrome daughters at risk of polycystic ovary morphology at puberty, not in puberty and after, and increased AMH in puberty, increased testosterone, insulin resistant, increase in bone age, and also not just increased adrenarche, but also and advanced puberty, advanced menarche. P1 study by Mimouni, he take prenatal IMH mouse. He used prenatal IMH mouse model to investigate PCOS transmission. Who give for this mice high amount of anti-Mullerian hormone, and like we see in the first model, they check for hypomethylation. They will know that the genes with DNA hypomethylation lead to overexpression of this gene, and this lead to overexpression of some inflammatory and increase insulin sensitivity in this mouse, which lead in hyperinsulinemia and resulting in hyperandrogenism. But treating this mouse with adding some methyl donor to DNA, which leads to hypermethylation of DNA. We know that hypermethylation of DNA lead to down expression of the genes, with resolving some metabolic and reproductive traits in this mice. Some woman supplementation with methyl donor like folic acid and high dose also improves metabolic function in obese woman. Neuroendocrine factor GABA signalic. Woman was treated with valproic acid, like woman treated in bipolar disorder or epilepsy or some to prevent migraine headache. Noticed to have to develop PCOS-like syndrome. Because of valproic acid, it increased GABA by interfering with the degeneration pathway of GABA. And by this time, it increased GABA production or GABA exposure in GnRH with subsequent increased frequency and amplitude. Woman with, even lean woman with PCOS had a high level of GABA in their spinal fluid in several sampling. And also androgen by itself, it also increased amount of GABA in GnRH neurons. Environmental factor like bisphenol A, it's mimic some estrogenic action. It's used for chemical production of plastic and resins, but we noticed that it also increase amount in PCOS woman regardless of body weight. Insulin resistance. In the majority of women with PCOS have insulin resistance, also regardless of weight, but increase with an overweight PCOS. There is paradoxical insulin sensitivities, as we say, in peripheral tissue. It has decreased or resistant and retained sensitivity or increased sensitivity in ovarian cortex and adrenal gland. Okay. Because of decreased sensitivity for insulin, instead of lipogenesis, it leads to lipolysis with high spillage of free fatty acid, which we know that in polycystic ovary syndrome, majority of women presented with visceral fat with visceral obesity. So all fatty acid from visceral fat and going by the portal system to the liver, directly to the liver, with increased lipid peroxidation in the liver, increased high level of increased free radical chemicals, which lead to increased fibrinogen, pi, also all coagulability proteins, and increase also triglyceride, very low density lipoprotein and low density lipoprotein, and increase and decrease high density lipoprotein, which leads to coronary artery disease by changing in metabolic profile. Diagnostic criteria for PCOS. It started in 1990 by National Institute of Health Criteria. It was in the beginning only of 2 criteria, and now it accepted Rotterdam criteria since 2003 and endorsed by International Evidence-Based Guidance in 2018, which include 3 criteria: hyperandrogenism, clinical or biochemical menstrual irregularity, and polycystic ovary on ultrasound. Okay, as we said, there is 4 types of phenotypes, 4 types for 4 phenotypes for PCOS. لا 10 أنا حكيت لك أنا مو علامة. Okay, first 2 phenotypes, it's connected with high metabolic disease more than last second 2. Okay, there is gap in physicians for diagnosis of polycystic ovary syndrome. There was one survey by telephone online questionnaire is known for America and Europe, asked 1,400 women, and third have taken more than 2 years before diagnosis was established. Frustration, most common emotional in PCOS women during workup for diagnosis, and have had seen more than 2 healthcare providers before the diagnosis was confirmed. عشان كده ليش هيك احنا صعب to establish diagnosis؟ أول إشي because of coexistence of criteria for polycystic ovary syndrome. Secondarily, many phenotype for PCOS. Also, there is no standardization for definition of hyperandrogenism, not clinical and not biochemical. And also changing in presenting symptoms throughout the life, according to the age or according to phenotype, or according to ethnicity, sorry. Okay, stepwise diagnostic approach. Here, I want just to notice an adolescent, we can't use third criteria of polycystic ovary syndrome for diagnosis unless 8 years of post-menarche or 8 years, 8 gynecological age, because of high prevalence of polycystic ovary morphology in this age, and inability use of vaginal probe. Okay, and also regularity of menses in adolescent patient is very difficult to establish, because normal menses or normal regular menses may be only after 3 years of menarche. Hirsutism is the presence of terminal hair in side, not in male pattern distribution. Hirsutism affect about 15% of women, but not all of them had polycystic ovary syndrome, but majority, about 95%. Only 5% account for another endocrinological disease. Here is 2 pictures. First, the more earliest mentioned in literature, German woman, and second, most famous woman mentioned in literature. She was working in circus. Both of them married. Second one, he married twice. Both of them had children, normal children without hirsutism. Okay, and 95% of hirsute patients have diagnosed, as we said, with PCOS or idiopathic hirsutism. Idiopathic hirsutism and without polycystic ovary, without anomaly in ovulation, normal menses, and without anovulation. Okay. Okay, clinical, also we said clinical hyperandrogenism, it's very difficult to establish because of differences in ethnic population. For example, in Chinese people, we use modified scale for score 2 to 3, and in our population, we use scale in range in 5 to 9 for many female population in نفس الشيء. اوكي هون بس بدي احكي لكم اياه انه testosterone we use in Kubat Hulima or in another clinic to put total testosterone level, but most accurate for diagnosis of hyperandrogenism is calculated testosterone, because the testosterone it's in very little amount in our body. Most of them they combined with sex hormone binding globulin or in albumin. And increase of androgen level twofold and prone for another investigation for some androgen producing tumor. Okay. Okay, polycystic ovary syndrome, we said about it, not to use in adolescent woman. Cardiovascular disease, an increase 4 to 11-fold in polycystic ovary syndrome, and high prevalence in polycystic ovary syndrome due to increased angiotensin production in the liver and increased reduction in synthesis of nitrous oxide. Also, a retrospective study was done in over 174,000 PCOS women, and they concluded that young women with PCO have increased incidence of major cardiovascular events like myocardial infarction, stroke, angina, revascularization, and cardiovascular mortality. Type 2 diabetes, also most of patients has insulin resistance. About 33, they fulfill criteria for metabolic syndrome. There is 5 to 8 risk increase in diabetic compared to age and weight matched control patient. But OGTT will not use for every patient upon diagnosis of PCOS. Three guidelines, they advise to do GTT or GTT if BMI more than 25 to 30 and age more than 40, and follow up if any clinical other risk factor for development of diabetes mellitus. Obesity, there is no pure relationship between PCOS and obesity, but because of insulin resistance is the root cause for obesity. All vicious cycle began with increased resistance to insulin. And reproductive feature, ovulation induction dysfunction in 75% of PCOS, and abortion, it's more frequently than in control. Endometrial cancer, 2 to 6.5 higher in women with PCOS, but routine screening for endometrial cancer has not routinely recommended unless if you see a patient even in her 30 or 40 obese patient with one cycle per سنة, طبعا هون advised to do people biopsy. Management, first step, it's life management, a decrease in our intake, calorie intake, calorie intake and physical exercise. It all may resolve menstrual cycle and improve fertility if we decrease only 5 to 10% of weight. Contraceptive pills, it's a first medical treatment and first line medical treatment. Use low dose contraception, low dose estrogen contraception because of decrease thromboembolic event. خلص okay. just here. We prefer to use third and fourth generation of oral contraceptive pills because of progestin. There has anti-androgenic effect and also on the low metabolic side effect. And use estrogen with minimum dose of ethyl estradiol, not Diana like we have to use in our clinic, not Diana. And FDA approved estrogen progestin contraceptive. Yes, it's the first place for use in PCOS. And metformin, last slide. Metformin, we add Adaton, generally in women with additional risk factor, like obese patient, proven insulin resistant, or other metabolic risk factor, not for all women. Okay, but a decrease beneficial effect of metformin, decrease in insulin resistant, decrease of hormonal adipokines, reduce in visceral fat, and reduction in incidence of type 2 diabetes mellitus. Okay, it's a short protocol, like we see, and it's from guidelines of evidence-based. First line at always weight loss. Second, at oral contraceptive with 20 microgram ethyl estradiol and noretidronol, any anti-androgenic progestins. Okay. And conclusion, the pathogenesis is multifactorial, insulin resistant, near uniform. Lifestyle intervention is primary management in metabolic disease. Oral contraceptive remains the first line medical therapy, and PCOS specific risk factors such as BMI, hyperlipidemia, hypertension need to be considered, and treatment have been tolerated to patient and cultural consideration, our consideration of Jaritha. Early attention to weight gain in childhood and adolescent and those of risk for PCOS may be important measurement of prevention. Shukran.